Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, my name is James Carr, and I am a professor of radiology at Northwestern University Feinberg School of Medicine. Welcome to this program, which is entitled MRI Workup of Ischemic Heart Disease, Insights and Innovations. I'm joined here today by Dr. Kate Hanneman from the University of Toronto in Canada, and also by Dr. Raymond Kwong from Brigham and Women's Hospital in Boston. We're going to spend the next 30 minutes or so talking about how we approach using MRI to detect and manage ischemic heart disease. And I'm going to just give a general overview of the MRI technique and protocols. So first of all, as many of you know, the cardiac MRI exam consists of multiple techniques. This is the beauty of MRI. You can combine cine imaging with perfusion imaging, with delayed enhanced imaging, and you can also do angiography at the same time. And you can look at anatomy and morphology with dark blood imaging. However, the basic cardiac MRI protocol is actually quite simple, and it's represented here, where you do a stack of cine images, as shown on the top, inject gadolinium contrast, wait typically about 10 to 15 minutes, and do delayed enhanced imaging. So the basic backbone of every protocol really consists of cine imaging plus delayed enhanced imaging. And that is represented in this schematic here, where you do the cine imaging first and do delayed enhanced imaging at the end of the overall protocol. Now, with a standard CMR protocol, you can speed up the overall protocol length, as shown here, by giving the gadolinium contrast a little bit earlier. In this case, it's giving the contrast before you acquire the short axis cine imaging. You could actually give the contrast right at the beginning of the protocol if you really want to shorten things up a little bit. And then you can add in other techniques, as shown here, such as mapping techniques, T1 mapping, also 2D and 4D flow. And this is interspersed at any point in the protocol. A lot of focus in recent years has been on developing a more rapid, simple CMR protocol. And this is shown here, where we use a much more accelerated technique for imaging the heart. So in this case, it's called real-time compressed sensing cine MRI, where you cover the heart, free breathing from top to bottom very rapidly, give the contrast early. You do a very rapid delayed enhanced imaging protocol. In this case, it's a motion corrected single shot technique where the patient can be free breathing, and it covers the entire heart in multiple orientations. And really, with this technique, you should be able to complete the entire CMR protocol in less than 30 minutes. In fact, this approach has been published a couple of years ago in the JCMR article, where they showed that a rapid CMR protocol, including stress perfusion MRI, can be completed in 30 minutes or less. And this really can have a huge impact on simplifying the overall CMR protocol and allowing it to occur in a relatively short period of time. Finally, there are many indications for cardiac MRI, and they're also shown here, and this was published in an SCMR position paper from 2020, but shows the myriad of indications that can be covered with cardiac MRI. We will be focusing on coronary artery disease and the evaluation of ischemic heart disease. So, Raymond, now that we've introduced the groundwork for acquiring cardiac images, can you tell us more about how you approach stress imaging?
Yeah, and at our program, we aim to protocol these stress tests in less than 30 minutes. What you're seeing here is the order of acquisition, namely vasodilatation induced stress perfusion typically covering 3 short axes. The stress you usually acquire with adenosine infusion or a combination of regadenoson and aminophylline reversal. Following that, we acquire a stack of cine function in short and long axis cuts. And then in our program, we'll also perform rest perfusion to compare against the stress perfusion. Following that, we perform late gadolinium enhancement. Altogether, the scan can be acquired in most patients in less than 30 minutes. And it's important to note that these protocols, the stress and rest perfusion should be separated by about 10 minutes and longer if your preference is to also acquire quantitation of myocardial blood flow, which is another feature that is quite unique with cardiac MRI. So here I'm showing a case of a patient who presented to the emergency room in my hospital with acute chest pain. He was noticed to have negative troponin levels, and also ECG were not specific for any ischemia. Given that chest pain, we proceeded to perform a stress cardiac MRI on him. And even though we acquire stress perfusion first, the way we prefer to read these scans, we look at the function and late enhancement first to look for infarction or any clear signs of cardiomyopathy. You can see that the stress function on top, the short axis stack, demonstrates the regional motion across all the myocardial segments are normal. There's no lack of thickening or there's any wall thinning. And this is matched by the lack of any late enhancement for infarction. Now, then we will look at the perfusion images. Here on this slide, that on the same patient, we typically give on the left side, the top row demonstrates the regadenoson stress, followed with the with the aminophylline reversal. On the top, what you're seeing is the apical, mid, and basal cuts of the short axis of the left ventricle. The bottom row, where you see the first pass blush perfusion, you can see the bottom row are the rest perfusion matching the top. So, so you can clearly see that this patient has a perfusion defect in the septum and the anterior wall, starting from the base, involving the mid and also the apical slice of the left ventricle. So very obviously, by qualitative perfusion, you can see that there is an ischemic focus, recording that he had no infarction on the LGE. Also, what's interesting with CMR is that what's not immediately obvious was the inferior wall. If you look at the basal inferior wall, also have a very small subtle perfusion defect. That wasn't very easy to see. Now, many programs, including our own, are routinely quantifying myocardial blood flow as a measure of blood flow that is more specific for ischemia. You can see that not only did it pick up the perfusion defect in the septum and the anterior wall, but also in the basal and mid slices, there's a subendocardial perfusion defect as shown on the right. The blue area, the basal and mid inferior wall also have hypoperfused area compared to the rest of the myocardium. The pink area are the adequately vasodilated myocardium. So in this case, it illustrates that this sort of technique, this CMR, stress CMR technique, is capable of giving you the obvious area of ischemia. On this slide, it can show you a polar plot of where the ischemic segments are, and also the degree of ischemia. You can quantify blood flow as shown on the table on the right, that you can quantify in the American Heart Association 16-segment model, the actual blood flow during stress and rest. And as I indicated, and I try to show here, the LAD territory related segments, as shown in red, are substantially low in stress perfusion. And the inferior wall or the circumflex related territory are moderately reduced in blood flow, as shown in purple. So this patient went on to have a coronary angiography, as shown here. Not only did it confirm there's a tight proximal LAD lesion with an acute thrombus that accounted for his symptoms. But there's a second focus of circumflex stenosis that is also accounting for the inferior wall perfusion defect is consistent with ischemia. So I think this case, the CMR illustrates both the qualitative and quantitative aspects of this technology.
Yeah, thank you, Raymond. Kate, do you have anything to add? Is your approach to stress perfusion somewhat similar to this?
Absolutely, yeah. Certainly in terms of the qualitative approach and quantitative data. The only thing I wanted to add is, of course, I work in a different country in Canada with different regulations, and so we don't have access to regadenoson for stress. And Dr. Kwong had mentioned that was one of the stress agents used. So we use dipyridamole with aminophylline for reversal, and that works really well. So just wanted to emphasize that there are several options for pharmacologic stress for stress CMR, and so depending on the country or region you work in and regulations, may need to be creative about the stress agents that's used.
Okay, thank you, Kate. So let's switch direction a little bit and let's talk about MRI, Kate, for imaging acute infarct. How do you approach imaging in this type of scenario?
Yeah, thanks, James. I love talking about cardiac MRI for in the setting of an acute MI. And I really wanted to start this case as this patient presented. This was a patient who came into our emergency department, and actually it was suspected to have an aortic dissection. So really this patient's journey started at our hospital with a CT to rule out dissection. And what was picked up, even in the emergency department, was the fact that there's low attenuation of the left ventricular myocardium. You can see that on the apex. And this is non-specific, of course. There's a number of reasons for this, but one of the potential causes for hypoperfusion is myocardial ischemia in the setting of an acute infarct. And that obviously would fit with a setting of acute chest pain. And here, even in this non-gated chest CT, we can see, really the underlying reason for this, where there's a plaque and obstructive plaque in the proximal LAD. And so this is how this patient presented. And of course had a cardiac MRI as an inpatient fairly shortly after their acute presentation. And I think the only thing I wanted to emphasize in terms of the protocol for acute indications, certainly acute MI, but similar protocols we would use for acute myocarditis, for example, really is the addition of edema imaging, in kind of the add-on on top of the efficient protocol that you went over earlier. And I think traditionally we used black blood, T2-weighted imaging is kind of the workhorse for that, and certainly many centers still use that, and I think that's excellent really for visual evaluation of edema, where we would be looking for myocardial high T2 signal or hyperintensity. And of course, that's really important to tell us about what's going on in a very acute setting, telling us about the fluid that's in the myocardium, in this case, in a patient with an acute infarct and the setting of ischemia and myocardial injury. Here, though, what I'm showing you is actually a T2 map. And so this is important that you think about it in protocol appropriately, because these need to be acquired before you give gadolinium-based contrast. So in that very abbreviated protocol where you talked about injecting gadolinium-based contrast, very early on, even at the beginning, this would be one of the indications or reasons that you want to think about doing your T2-based imaging before you give contrast, of course. And one of the reasons I really like our need of T2 maps in this scenario is not only can we visually see that there is a high T2 signal and telling us that there's myocardial edema in the LAD territory, not only at the anterior wall on this mid-ventricular short axis slice, but also involving the septum. Is we can actually quantify that. And so here, I don't think the diagnosis is in question. We can see that this is transmural. It fits the expected territory of that the LAD would supply, of course, and fits with a patient's clinical presentation. But for other acute processes like acute myocarditis, for example, where you may want to bring the patient back and really see whether that edema is improving, of course, the T2 map is actually quantitative. So just wanted to emphasize that. And for viewers who may not be familiar with mapping, if those aren't integrated into clinical protocols, I just want to emphasize that the color scale is arbitrary. Different post-processing vendors will use different color scales. You can modify it as well. So really important that you interpret the color maps if you're looking at the color scale image rather than the grayscale in the context of the actual, the color lookup. And again, those are not standardized as of yet. And then the other key sequence in terms of tissue characterization in the setting of an acute infarct is LGE and our late gadolinium enhanced imaging. So unlike in a chronic infarct or a mid infarct or most of the non-ischemic cardiomyopathies where late gadolinium enhancement to the myocardium is typically telling us about fibrosis, in the setting of an acute MI, as in this patient, the late gadolinium enhancement is being retained because there's acute myocardial injury. So the myocytes have died because of ischemia in many cases, and that abnormal tissue is holding on to contrast. So I really like to emphasize the point that while we often think about myocardial LG as being equal to fibrosis or telling us about fibrosis, that's not the case in very acute presentations like an acute MI. And so when I'm interpreting these images, I think it's really important that we talk about the distribution, as we heard Raymond talk about before, using the AHA segments to talk about which segments are involved. We also talk about, of course, whether base, mid, and apical segments are involved. And then also the wall thickness, and that's really important to understand how long the myocardium was ischemic before it was reperfused, of course. And another key finding that you want to look for and comment on, of course, we have microvascular obstruction. Sometimes we'll talk about that as MVO. And that is that area of very low signal intensity within the myocardium. And I think the simplest way to think about this, sometimes when I'm explaining it to our trainees, we'll talk about that myocardium was so infarcted, so dead, that the gadolinium contrast couldn't even get there to be retained. So, there's no reflow. That has not been reperfused. And we know that this is an adverse prognostic indicator. So patients who have an acute MI and we have microvascular obstruction tend to have a worse prognosis. And so really important that we comment on this. And we do need to distinguish this from thrombus, which is more common, and thrombus would be layering within the blood pool, not within the myocardium. But really, this is my approach to acute myocardial imaging. The key components are the edema imaging, whether you're using kind of traditional T2-weighted sequences or your T2 maps, as well as your LG imaging, and really commenting not only in the distribution, the transmurality, which is really important for prognosis, and then looking for some of those complications like microvascular obstruction.
Okay, thank you so much, Kate. That's extremely informative. And I'd like to just talk a little bit about how MR imaging of acute infarct differs from imaging a chronic infarct, and show that in the context of a few cases here. So we have three different examples of patients with chronic infarcts. And if I draw your attention just to the case on the left, you'll see the Cine two-chamber view on the top and the delayed enhanced imaging on the bottom. This is really a classic infarct where you've got thinning, akinesia of the anterior wall, and then there's transmural enhancement of that same involved area. The protocol for this is getting back to the very basic protocol. We do Cine imaging, inject contrast, and then image about 10 or so minutes after the contrast injection. Couple of things I just want to point out is, first of all, with regard to the protocol, most of us do tend to use, in practice, anywhere from a dose and a half up to double dose of contrast. Increasingly, we're using single dose of contrast. Just bear in mind that if you do use single dose of contrast, you may want to image a little bit earlier post the contrast injection, and that lends itself quite well to imaging the contrast earlier to shorten the protocol. So that's an important point to remember. The second is in the interpretation here. So one of the rules of thumb we use when we're interpreting chronic infarcts is to describe the transmural extent of the infarct. And you can see in case number one here on the bottom that the entire wall is involved by the infarct. So it is transmurally enhanced. And that's important to point out because that means that that patient has a low chance of recovery of the myocardium post-revascularization. This is all based on a study by Kim et al. From the early 2000s, where they showed that if patients had over 50% of the wall thickness involved, there was a low likelihood of recovery, whereas if it was less than 50% of the wall thickness involved, there was a greater chance of recovery. So this 50% number is really the kind of golden cutoff number. Case number two, again, you can see that there is thinning out towards the apical part of the septum. And if we go to the image on the bottom, you can see that that thinned akinetic segment is also transmurally enhanced. So clearly there's an infarct here, and the infarct is involving the basal and mid portion of the septum as well. But you'll also notice that there's what looks like a mass attached or lying against the thinned and akinetic wall, seen on the cine image on the top, and also seen on the delayed enhanced image on the bottom. So this is a mural thrombus, which is complicating a chronic infarct in this case. And as Kate mentioned in the last case, one of the complicating features of acute microvascular obstruction or no reflow zones is distinguishing it from thrombus. And this is an example of thrombus, and it's clear that this is lying against the wall as opposed to lying within the wall. Another alteration to your technique that you can do to try and prove that it is thrombus is you can perform so-called long TI imaging. And long TI will cause the thrombus, so the blood in the thrombus, to be suppressed because of the contrast differences between blood and myocardium. And this is a technique that can be added on if you're trying to prove that this is thrombus. So a chronic infarct complicated by mural thrombus at the apex. And then if we move to case number 3, again, you can see akinesia and wall thinning at the apex and also involving the inferior wall. But I think what's most obvious here is the bulging from the inferior wall. So the inferior wall of the heart in this case is what's called dyskinetic. The wall is moving in the opposite direction to what it should normally be doing. There's also transmural enhancement in the wall. So this indicates that this patient has developed a true aneurysm as a result of their chronic infarction. And a true aneurysm is characterized, first of all, by dyskinesia and wall thinning, but also it has a wide neck. And you can see here that the neck into the aneurysm is very large and voluminous, in contradistinction to a false aneurysm, which is a narrow neck. A false aneurysm or pseudoaneurysm of the heart is a lot less common. It's a much more serious event, which is frequently fatal. Whereas a true aneurysm is something you come across a little bit more commonly in the context of chronic infarction. So these are just 3 examples of chronic infarction to finish off our case presentations, and also to contrast that to acute infarction, as shown by Kate, and also stress perfusion to diagnose ischemic heart disease, as shown by Raymond. So I'd like to move on now to the panel discussion and ask our experts some questions just about cardiac MR in general. And first of all, maybe I'll address this to Kate. How do you think cardiac MR is easier now compared to even 5 years ago?
I totally agree. I think cardiac MR is easier now than it was even 5 years ago, and certainly 10 years ago, for a number of reasons. I think we've really moved away as a field from the very comprehensive one-stop shop protocols where we maybe did everything just in case we needed it. So including phase contrast imaging, all the tissue characterization, to very efficient and tailored protocols. Certainly that's the case in our center, but as highlighted earlier, the SEMR has this efficient protocol. And so really we're answering the question, for an individual patient. And I think this lends itself really nicely to efficiency and making our job on the both post-processing and interpreting side a lot easier. The other point, I think, is we've seen tremendous innovation in terms of the sequences we have available, the resolution of them, the equipment as well, of course. But really, that's been a tremendous advancement over the past couple of years. And as you've said, in many cases, we're decreasing the contrast dose, but we still have really good signal to noise and contrast to noise ratios. So hopefully that makes all of our jobs easier in terms of interpretation.
So thank you, Kate. Maybe Raymond, we can't really talk about anything in medicine these days without talking about artificial intelligence. How do you think AI is currently impacting cardiac MRI, and how will it make our lives easier?
Yeah, that's a very important question, James. AI indeed has been around for quite some time in cardiac MRI, and it marries the strength of cardiac MRI very well with AI, because of the wealth of information that you can gain from the multiple sequences, as we have such a collection of techniques, and AI really facilitate the integration of this data. For many years, indeed, AI already has been in the post-processing side, in consistently now measuring the heart function. I remember that for many years now, we have not had to place tracings on the heart. The quantitation of heart function, cardiac masses, they're all automated across all the software vendors. And AI actually has been increasingly used in the sequences. Many of the techniques that are coming out as product across all the vendors actually have AI built in for acquisition and making the data acquisition more consistent, that suppress cardiac motion or suppress artifacts. There's a lot of AI built in. On the commercial side, also it's good to see that all the vendors are developing AI scanning based method. There is commercial available method in the US that automatically scan the whole study instead of 100 clicks in a study. It may actually reduce it down to 5 to 10 clicks. It's actually feasible. Of course, there are some variations within different studies, but at Brigham ourselves, we use AI guided scanning in majority of our CMR cases. So I think these things will continue to improve and will make the technology much more available and simpler.
I agree, and I'll just add, I really like how Raymond phrased it as kind of talking about AI in terms of the acquisition and analysis, and I think we've seen tremendous advancements in both. And the only point I wanted to add in terms of acquisition is, as Raymond said, we've moved away from having to have very specialized technologists, who are trained in cardiac MRI in order to acquire the cardiac imaging planes to many of these AI guided algorithms for acquisition are almost 1 or 2 clicks, as Raymond said. And I think it's important to actually link that with the potential to improve access. So smaller communities might have an MR, but they might not have a trained cardiac MRI tech. And so I think there is really the potential for these tools to help us increase access in underserved communities. And I think there's more AI advancements in the future. Certainly we've seen remote scanning become available, and so maybe one cardiac MRI technologist who's trained in a central location can even remotely monitor several studies. And so I think there's really going to be quite a lot of potential for that, and absolutely agree with the time savings both on the scanner, allowing us to have more efficiency and potentially scan more patients for operational efficiency, but also in terms of the AI that we use in our post-processing tools, which has absolutely very much changed our workflows in terms of how we report.
Well, thank you both. I think you have outlined very clearly what the future of cardiac MRI will be like in the next few years, both with AI, simpler protocols, also an important point around how this is just an easier test, I think, to implement for technologists, for scanners, compared to what it was 10, 15 years ago. Raymond and Kate, thank you both for your input and for this great discussion. It's much appreciated, and I hope this whets the appetite for everyone listening to continue to advance your cardiac MR programs and hopefully get involved in cardiac MR if you're not doing it already. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.